And now I shall be coming to my own talk, which is approach to an Epiphora patient, management pearl. How should we approach a patient of Epiphora? First of all, what is Epiphora? As we all know, Epiphora is watering due to abnormal tear drainage system. It has to be differentiated from lacrimal or pseudo-epiphora, which is very common condition in Indian setup, and pseudo-epiphora or lacrimation is watering due to excessive tear production. So in Epiphora, Lacus lacrimalis-wet. Whenever a patient enters into your OPD, and if you see carefully, you will immediately able to recognize that patient is of true Epiphora, because this area which is known as lake of tears or Lacus lacrimalis, a space in front of caruncle, this will be full of tears in problems of Epiphora, that is problems created due to abnormal tear drainage system, wherein in lacrimation or pseudo-epiphora, there will not be any full Lacus lacrimalis. This area would be devoid of tears, though patient will complain of excessive tearing. As you can see in this particular photograph, here patient is having abnormal surface and this is creating excessive lacrimation, but it is not a case of true Epiphora, where here you can see a full Lacus lacrimalis. So any patient entering in your OPD with full Lacus, you will immediately got to know that patient is having problem in tear drainage system. A word about reflex tearing or lacrimation, excessive lacrimation, not true Epiphora. This is very common in dry eye as a compensatory mechanism, then ocular surface disorders, keratoconjunctivitis sicca, conjunctivochalasis, ocular cicatricial, pemphigoid, etc., conditions of raised IOP, corneal problems, also certain neurogenic hypersecretory disorders. So we will not discuss this particular condition now onward, and we would be concentrating ourselves to the true Epiphora. As it was graded by Saline, in grade 1 Epiphora only in outdoor and during windy times, grade 2 outdoor Epiphora, no indoor Epiphora, and grade 3 outdoor and indoor Epiphora. So now we know that grade 3 pertains only to the true Epiphora, while grade 1 and 2 are actually reflex lacrimation. So causes of Epiphora, first one should always see the punctal position. Malpositioned puncta due to ectropion will give rise to severe tearing. No prizes on diagnosing this, but you need to diagnose these kind of cases, subtle cases of a punctal ectropion, and you can see a full Lacus lacrimalis. So you will know that there is some problem in tear drainage system, and this problem is due to grade 1 or 2 of ectropion, and you have to deal with that. Typically, syringing would be patent in this kind of patient, and you should be dealing with ectropion. Some minor surgical procedure, either conjunctivoplasty or lid tightening procedure need to be done. Then Epiphora can be caused by obstruction anywhere in tear drainage system, puncta to nasolacrimal duct, and also a certain number of cases are there of lacrimal pump failure, wherein you do not have any organic blockage, but still patient has got true Epiphora. This is because of weak orbicularis creating pump problem. So in evaluation of Epiphora, you need to have a step ladder approach. History and preliminary examination typically give you proper diagnosis in 80% of cases. Syringing is needed only in rest of the cases to diagnose a case. Diagnostic probing, very few cases, and Jones dye test for functional cases, around 1% of total Epiphora cases it is required. DCG and scintillography, I don't think we have, any of us have the facility of this, but these are of, DCG is required in certain cases. Typically in lacrimal diverticula, you cannot diagnose this particular condition without DCG. So history and preliminary examination, as I told you, they are helpful in most cases. By examination only, you will be able to know there are certain facial problems, telecanthus, epicanthus inversus, that is, as it is there in this particular case, and they create Epiphora because of canalicular stretching and inversion of lid, etc. Then punctal examination, very important to get punctal atresia and stenosis, especially in post-cataract surgery cases because of steroid. Now we all know that excessive use of steroid, typically dexamethasone, creates punctal atresia. Then punctal opposition and lid snapback test to diagnose ectropion. And in a given case of nasolacrimal duct block, if you see carefully, there will always be a fullness in sac area, and you just press your finger over that fullness area, you will have regurgitation on pressure. So in these type of cases, you do not require syringing or anything else. If regurgitation is positive, it means the patient is having nasolacrimal duct block and he or she requires surgery. Then a very important test is bitter test. Instill a bitter eye drop, typically chloramphenicol in conjunctival sac. If patient can taste it within 5 minutes, it confirms lacrimal passage patency, functional as well as anatomical both. So in today's era, we don't want to subject patient to syringing, which is a traumatic procedure. So better to do this bitter test, and you will have a good idea about the lacrimal passage. Then the lid snapback test. This is to diagnose ectropion. Just pull back the lid and release it. Normal lid will immediately go back like this, while ectropion lid, they will go very slowly and they will go back according to the severity of ectropion. In grade 3, they will go back after 5 seconds. In grade 4, they will never return back to its position and continue to hang down. Anatomical test, we all know about them, but we should know how to do them properly. Syringing, as I told you, indiscriminate syringing has to be avoided because it may cause more harm than doing good, and it has to be preceded by regurgitation on pressure over lacrimal sac area, because if it is positive, it means patient is having nasolacrimal duct block and patient requires surgery. So no need of doing any syringing in these type of cases. But of course, on table, one must always do syringing before doing any surgery. Then the bitter test, very important test I told you. If it is positive, it means there is patent lacrimal system. You don't require to do syringing. And one must be very, very careful if there is blood-stained discharge with a solid swelling on regurgitation. Then the patient may be having tumor or granulomatous infection or fungal infection, and you have to do cytology or culture of these cases. I have seen 2 cases of lacrimal sac tumor, and I think 2 cases of rhinosporidiosis and 1 fungal granuloma of sac. So these are there, and one must be able to diagnose these cases if they are there, because if you do syringing in a tumor case, then you may create havoc. Then before doing syringing, you must always check punctum dilator and cannula for sharp edges. Avoid using very fine cannula. I have seen this is a very common practice, people using 26 gauge, 27 gauge cannulas. They are bad because they can create false passage because of thinness, and they will be misleading reflex from around the cannula also. So you have to use a cannula which snugly fits into the canalicular system, ideally is 23 gauge, so that there will not be any misleading reflex from the side of cannula, and you will have proper diagnosis on table. Then your syringe has to be good. You should always check syringe before doing syringing. There should be smooth movement, and always use salty fluid like ringer lactate. Then this is the proper way of doing syringing. Interpretation: if mucopurulent fluid comes out through opposite puncta, NLD block, no confusion. If clear fluid comes out through opposite puncta, there can be 2 conditions. One has to always differentiate between these 2. Immediate reflex of clear fluid, common canalicular block, and patient require canalicular DCR. There is clear fluid regurgitation, but there is little swelling on the sac area, very tiny swelling. In these cases, you just wipe off all the area after doing syringing and press over the sac area. If a tiny drop of fluid is coming out, is regurgitating from the punctum, it means patient is having nasolacrimal duct block with small and uninfected sac, and probably you can be successful by doing DCR alone. So this is important to diagnose this particular condition. And if clear fluid from same puncta, canalicular block. So in complete NLD obstruction, there is hard stoppage, and as I told you, mucopurulent fluid comes out through opposite puncta. In common canalicular block, soft stoppage, and a clear fluid comes out immediately, and you have to differentiate this with small fibrous sac with NLD obstruction, as I told you. Canalicular obstruction, your cannula may not go inside the canaliculi. And partial nasolacrimal duct obstruction, some amount of fluid will come out in nose, as well as it will reflux through the opposite puncta. So Jones test will differentiate these conditions very easily. Diagnostic probing, just to ascertain the diagnosis in case of confusion, and just to help differentiate between CC block and NLD block in difficult cases. CC block, as I told you, there will be soft stroke and there will be medial movement of medial canthus on probe movement. This is common canalicular block and this is nasolacrimal duct block. Probe is growing right up to the bone. Functional test, traditionally they are done when there is no evidence of obstruction in anatomical test, but patient is having true epiphora. There is a full lacus lacrimalis, but syringing is patent. So obviously there is something wrong with the patient's tear drainage system, but syringing is giving patent test. It does not mean that patient is all right. So do a bitter test. It's very simple, as I told you. Instill a bitter eye drop like chloramphenicol, and if patient tests it, it means functional patency as well as anatomical patency. Then there are other tests: Flourescein dye disappearance test, Jones dye test, lacrimal scintillography, etc. Fluorescein dye disappearance test, it is done in children. You cannot do syringing here. Put a drop of fluorescein into the conjunctiva and examine after 5 minutes. Typically, after 5 minutes, there is very little or no dye. But prolonged retention, it means patient is having some amount of lacrimal drainage system block. So this is the grading of fluorescein dye disappearance test. Then the Jones dye test. This is done in patient with patent syringing or partly patent syringing, but patient with true epiphora, as I told you, a full lacus lacrimalis patient. So Jones type 1 test or primary dye test, put fluorescein dye. After 5 minutes, try to check for dye inside the nose, just under inferior turbinate by a cotton tipped applicator. Positive, it means dye is detected in the nose, it means patent system. Negative, no dye is detected, it means either an absolute obstruction or a partial obstruction or a failure of pump. Now how to differentiate these three conditions? This is type 1 test. This is type 2 test. This will differentiate these three conditions: complete of regurgitation, no fluid in nose, total NLD obstruction, as it is diagnosed also in simple syringing. Then if you do syringing after doing type 1 test or after wiping off the dye from conjunctival sac and flushing the excessive dye from conjunctival sac, then you do syringing. This is Jones type 2 test. And a positive test means recovery of dye stained fluid inside the nose. It means a partial NLD block, because you can negotiate partial NLD block by forceful syringing. But a negative Jones 2 test means recovery of unstained fluid, though the patient will have fluid inside the nose, but there will not be any dye. So it means a defective lacrimal pump mechanism is there. So dye has not gone into the lacrimal sac area, but anatomical patency is there. So these are very difficult to manage cases. You don't do typically sac surgery in these cases. So this is just to summarize. A patient of watering, if lacus lacrimal is full, means patient is having epiphora. If lacus is dry, patient is having typically pseudo-epiphora or excessive lacrimation. Here the bitter test would be positive, so do not do any management of epiphora in these patients. Then you do syringing. If it is patent or partly patent, then you have to go for functional tests like bitter test or Jones dye test, and you have to differentiate between functional NLD obstruction and a partial NLD anatomical obstruction. And obviously if syringing is blocked, it means there is some problem in some anatomical blockage in lacrimal drainage system. Then the imaging technique, DCG, not done very frequently. Here you inject urographene dye and take serial radiographs. Diverticulas can only be diagnosed by this particular procedure. Scintillography, it is only of academic interest. Just deliver technetium-99 by a micropipette through to the inferior sac, and then the tracer images the dye through gamma camera. So this gives you about idea about the functionality of lacrimal system. CT and MRI is done in traumatic cases. Then lacrimal endoscopy, this is a new tool. 1 mm diameter rigid endoscope can be inserted, and you can inspect the lining mucosa of lacrimal system, its content, and people are doing surgery by lacrimal endoscopy also. So I think I'll finish off with my presentation here.